Good morning, everyone. It's just past 8, and we are really excited to have Dr. Emily C. Presenting to us all the way from Melbourne, where I think it is 10 o'clock at night. So we are really happy that she is staying up and chatting with us about AKI. So Dr. C is an intensivist and nephrologist at the Royal Melbourne Hospital. She's a Senior Honorary Fellow at the University of Melbourne and an Adjunct Fellow at the Monash University. She's got a master's in medical stats from Oxford and a PhD in clinical medicine from the University of Melbourne. So thank you for presenting to us today.
Thank you. I'll just share my slides.
Looks good.
All right. Perfect. So today I'm going to be presenting on contemporary concepts in acute kidney injury. And I've got no disclosures that are relevant to this presentation. So we're going to cover some of the current themes in acute kidney injury through this presentation, ranging from current updates in its epidemiology to the pathophysiological mechanisms that can contribute to injury, what our current management is, and then what some of the targeted therapies currently undergoing phase 2 and phase 3 clinical trials are, including angiotensin II, amino acids, complement inhibition, sodium bicarbonate, and lastly, vitamin C. So acute kidney injury is a heterogeneous clinical syndrome that describes an abrupt reduction in glomerular filtration rate. It's currently defined by the KDIGO criteria as a 50% increase in serum creatinine over 7 days, or as a 26.5 micromole per litre increase in 48 hours, as a reduction in urine output to less than 0.5 mils per kilo per hour for 6 hours, or as the requirement for acute kidney replacement therapy. Of note, there have been several biomarkers that have been tested over the last 10 to 20 years to try and refine the definition for acute kidney injury, but none of them have been sufficiently, have had prognostic capacities that exceeded serum creatinine. And so although it's likely that in the future we may use biomarkers to either re-stratify or to define acute kidney injury, it's currently used largely in a research purpose. Within acute kidney injury, we can identify several disease phenotypes, and these can broadly be classified based on AKI severity as stage 1, 2, and 3, AKI duration, so transient AKI less than 48 hours, persistent AKI up to 7 days, and then beyond 7 days, acute kidney disease until a patient may meet the criteria for chronic kidney disease at 3 months. It can also be classified as a single episode or as recurrent, and each of these different phenotypes carry different prognostic implications in terms of the risk of death, but also the risk of persistent organ failures, including chronic kidney disease. So currently, acute kidney injury is estimated to occur in as many as 20% of hospitalised patients, but as many as 25 to 50% of critically ill patients, especially in patients with sepsis and those undergoing cardiac surgery. As many as 10% of patients with acute kidney injury will require kidney replacement therapy, which has significant implications for health services in terms of resource utilisation, but also cost. Of great concern, the incidence of AKI is expected to double over the next decade. So we really need to have a careful think about how we're going to manage all of these patients and perhaps also what their subsequent risk of chronic kidney disease will be. When a patient develops acute kidney injury, it tends to be a balance between their risk factors and their susceptibilities, and then also the presence of precipitants. So various risk factors have been described, including sex, extremes of age, black race, diabetes mellitus, but then also several precipitants, including sepsis, major surgery, and exposure to nephrotoxic drugs. And it tends to be the balance between these risk factors and precipitating factors that determines whether a patient will manifest what we recognise as acute kidney injury. We've said acute kidney injury is a very heterogeneous syndrome, and that's true. It's not a single disease entity. And there are several potential mechanisms that can contribute to injury. And it may be that in a single patient, there's one dominant mechanism, or there may be several mechanisms at play. The mechanisms can broadly be classified as inflammation, with activation of both the innate and adaptive immune system, creating a pro-inflammatory milieu, followed by cytokine release, complement activation, and coagulation. Next, alterations in the macro and microcirculation. So this could be resulting from hypovolemia with medullary hypoperfusion, or conversely, hypervolemia with venous congestion. At the microcirculatory level, there can be altered renal blood flow through both the afferent and efferent arteriole, which is increasingly believed to reflect dysfunction of angiotensin II signaling. In terms of metabolic reprogramming, reprioritized energy expenditure is well described, especially in animal models. And this describes essentially prioritization of cell survival at the expense of organ function. There's also reprogrammed substrate utilization and restoration of mitochondria. So not only does the dominant mechanism vary between patients with a particular insult, but it can also vary within an individual patient across their time course. And so sepsis is a very good example of that. Because a patient with sepsis at the beginning of their disease trajectory can have a very pro-inflammatory milieu, and a couple of days later can have a predominant anti-inflammatory cytokine release. And this makes it really difficult for us to test therapies like anti-inflammatory therapies, given heterogeneity, not only between patients, but also within patients along their time course. We currently don't have any good ways to really identify in real time what the dominant mechanisms are. So we've previously classified acute kidney injury in terms of etiological subphenotypes. So things like sepsis-associated AKI, cardiac surgery-associated AKI. But what we're increasingly recognizing is that it's common that different etiologies can actually have the same mechanisms at play or the same subphenotype. And that if we classified patients according to those subphenotypes, we may then have more luck at testing targeted therapies. For example, if we've got someone with sepsis who's febrile, who's hyperdynamic with high cardiac output, vasodilatation, they in many ways behave very similarly to a patient who's just had cardiac surgery, who's also febrile, hyperdynamic, and has a vasodilated circulation. And it's likely that a therapy that works in one patient may also work in the other. So this is still a relatively novel approach to how we're classifying AKI, but it's likely that over the next 5 to 10 years, we may see more trials actually try and clinically enrich the study population according to a more specific subphenotype of patient in order to better understand which therapies may benefit patients. So I think understanding or predicting which mechanism will be active and contributing to injury in a particular patient is still something that very much eludes us. And it's likely and actively hypothesized that a patient's genetic makeup is one of the predisposing factors to what their subphenotype of AKI might be. So, for instance, if you've got two patients that have the same insult, so both patients are exposed to a severe infection resulting in sepsis, it's believed to be the genetic differences between patients in terms of gene activation and gene suppression that determines whether or not they'll get acute kidney injury and how severe the injury may be. And then going one step further, it may also be that two patients with acute kidney injury may have genetic differences that determine what their response to therapy will be. So it may be sort of single nucleotide polymorphisms in the renin-angiotensin system or in inflammatory cells that are contributing to both the expression of the disease in the patient, but also the subsequent response to therapy. And certainly there have been a number of studies and systematic reviews looking at the genetic predisposition to acute kidney injury. And in general, these have been relatively small and nowhere near large enough to actually make any definitive conclusions, but certainly a number of single nucleotide polymorphisms have been identified that may actually explain some differences between patients, and that moving forward may help us to guide therapy in terms of patients, especially those in the intensive care, and what therapies may benefit them. So in the absence of advanced real-time genetic testing to help guide that decision-making, we're currently left in a state where we've got no specific targets for this heterogeneous clinical syndrome. We've got no effective therapies, and so our guidelines are not prescriptive about how acute kidney injury should be managed. In fact, really, it's all supportive care. It's about removing further insults, so stopping nephrotoxic drugs, checking drug levels, and also adjusting doses as appropriate. It's about optimizing renal perfusion if patients are bleeding or have a circulation that's abnormal, and also reversing biochemical derangements that may otherwise lead to the requirement for kidney replacement therapy. So, building on the idea that different pathophysiological mechanisms contribute to injury in different patients, there's been a new paradigm where we look at the different interventions and therapies that are being tested and which sort of pathway, we classify them according to which pathway of injury they act on, so that perhaps we will eventually be able to enrich these studies to determine some interventions that may work for specific patients. So if we look at the entire nephron, we can broadly go into the pathophysiological mechanism categories of dysfunction of the renal, macro and microcirculation, inflammation, and oxidative stress. And we're going to go through each of these interventions now. So the first one we're going to talk about is angiotensin II. So angiotensin II is a vasopressor, which is a non-catecholamine vasopressor that was first really tested in the Athos research program. So Athos-3 was an international randomized controlled trial in which 321 patients who already had catecholamine refractory vasodilatory shock. So these are patients who are already on high doses of norepinephrine in the intensive care, and who had persistent hypotension and shock despite that, were randomized to receive either angiotensin II or placebo. And as you can see in the blue line, there was a massive increase in the mean arterial pressure following initiation of angiotensin II. So it was certainly an effective vasopressor in that it could increase blood pressure. Now, that was the primary outcome of the study, because that's what the FDA required to approve it for use in clinical practice. And the trial wasn't powered for any of its secondary outcomes. However, if we look at all-cause mortality at day 28, for example, we can see that at least numerically there was a difference in the number of patients who died in the angiotensin II group at 46 compared to the placebo group at 54%. With a hazard ratio that did not reach significance of 0.78. When we do a Bayesian back-of-the-envelope re-estimation using the available data from the supplementary analyses, we can see that the posterior probability that the mortality difference favoured angiotensin II was as much as 92%. So there's definitely more to hear from this story. But perhaps some of the most interesting elements of the Athos-3 trial have come from its secondary analyses. So this is a secondary analysis that just looked at patients who required renal replacement therapy as part of their organ support in the context of severe vasodilatory shock. So looking at this high-risk group, we can see that patients who were randomized to angiotensin II in the solid black were more likely to be alive than patients in placebo over the follow-up period out to 28 days. And we can see the hazard ratio of 0.52 supporting a survival benefit. Interestingly, we can also see that patients who received angiotensin II in the solid black were more likely to liberate from renal replacement therapy with a hazard ratio for liberation of 2.90 compared to placebo. Again, this is a secondary analysis and needs to be confirmed prospectively, but certainly interesting that patients with severe vasodilatory shock, who are often identified as patients who'd likely have dysfunction of their RAS, were more likely to survive and liberate from renal replacement therapy if they received angiotensin II. So this study took that one step further, because angiotensin II is a unique vasopressor in that there's a readily available biomarker for the endogenous function of the system. So the renin-angiotensin system is something that we test not infrequently in clinical practice, often more for the workup of overactivity. But certainly it's been hypothesized that a high renin level suggests dysfunction of the renin-angiotensin system in shock, such that low endogenous production of angiotensin II stimulates significant renin release. And so the ATHOS-3 investigators did some work where they dichotomized the study population at the median and grouped patients into high renin versus low renin groups. So this graph is the low renin group, and you can see that there is no difference in patients' survival when they received angiotensin II versus placebo if they had a low renin. And that's the group in which we suspect that the RAS remains functional. However, in patients who had an elevated RAS, suggestive of RAS dysfunction, we can see a significant difference between angiotensin II and placebo groups favoring angiotensin II in terms of survival, with curves separating very early, remaining separated proportionally until at least day 28. Even more excitingly, not only did patients with a high renin appear to have a mortality benefit, but they were also more likely to liberate from renal replacement therapy by day 7 at 43% versus 12%, the p-value of 0.01. So again, hypothesis generating that potentially renin could be used as a biomarker to help identify patients in whom dysfunction of the microcirculation mediated by dysfunction of the RAS is a key contributor to acute kidney injury. So in the sort of wake of ATHOS-3, which was published now almost 5 years ago, there have been a number of pieces of work that are starting to unpack this story. So in Australia, we're currently running the Aramis research program. So we've published our pilot study and we're now doing a phase 2B RCT looking predominantly at renal outcomes. We've got the ATRAC trial in cardiac surgery patients and also dark sepsis. So certainly a space to watch. There's some exciting data coming out in the angiotensin II arena. So next, we're going to talk about amino acids, which are also hypothesized to work through at least perfusion to the kidneys. So there's been a lot of talk about amino acids recently following publication of the Protection trial a couple of months ago. So Protection was a multinational double-blind randomized control trial of cardiac surgery patients who were undergoing cardiopulmonary bypass. And patients were randomized to receive either a balanced mixture of amino acids at a dose of up to 2 grams per kilogram per day, or placebo, and that was for up to 3 days, and it was censored at ICU discharge. The primary outcome was the occurrence of acute kidney injury, which was defined using the KDIGO criteria. So both groups received very similar volumes of filling and also similar total times of exposure to the intervention, so 30 hours versus 31 hours. And we can see that in patients who were randomized to the amino acid group, they had a much lower incidence of AKI at 26.9% versus 31.7% in the placebo group. Now, this was predominantly driven by a reduction in stage 1 AKI, which is important because for many patients, stage 1 AKI is not associated with significant increases in mortality and morbidity, depending on which study you use. But certainly stage 2 and stage 3 are. And the study did show a difference in the risk of stage 3 AKI between groups, but wasn't adequately powered to fully investigate that difference. So there are a couple of secondary analyses that are planned from Protection, which are going to be really important in terms of determining whether this is an intervention we should start to routinely roll out in clinical practice. So the first of those is looking at the patients who had chronic kidney disease at enrolment, because these are the patients for whom stage 1 AKI is more likely to pose a significant problem. So if your starting creatinine is, 180 and you have stage 1 AKI and go up to 270, that's probably going to have a more significant impact on mortality and morbidity compared to if you start at 65 and you go up to 95. So that should be coming out in the next couple of months. Also, there'll be a secondary analysis looking at the risk of chronic kidney disease in amino acid or chronic kidney disease progression in amino acid versus placebo. And since AKI is still considered a surrogate outcome rather than a patient-centered outcome, chronic kidney disease will help reinforce whether or not this is something that changes meaningful outcomes for patients. So another secondary analysis to look out for. And this just shows that the separation between groups started from about day 1 in terms of the proportion of patients without AKI. Next, we're going to look at ravulizumab. So ravulizumab, a lot of nephrologists and hematologists may be aware of because we use it in other conditions like atypical hemolytic uremic syndrome. So it's a terminal complement inhibitor, but the long-acting version of eculizumab. So the rationale for this intervention is that we know that cardiac surgery-associated acute kidney injury occurs in more than 50% of patients with chronic kidney disease. So they're certainly one of the highest risk populations undergoing this surgery. And unfortunately, chronic kidney disease and ischemic heart disease tend to go hand in hand. It's hypothesized that the damage and inflammation that's induced by the ischemia reperfusion injury, but also by cardiopulmonary bypass, is then amplified by activation of complement associated with endothelial damage. So it then would make sense that treatment with a terminal complement inhibitor prior to the onset of ischemia to try and mitigate that complement activation stage may decrease the risk of major adverse kidney events. So this is a study that's being done by Alexion, and they're including, it's a pharma study, phase 3 international RCT of adults who are having non-emergent stenotomy with cardiopulmonary bypass. So they're essentially including all types of surgery apart from single vessel CABG without a valve, and patients need to have CKD with a GFR of between 20 and 60. So they're aiming to recruit 736 patients, and the study's been going for at least 12 months now. So hopefully we'll have some results in the next sort of 18 months to help us understand whether this is another intervention that for a high-risk group like the chronic kidney disease patients for whom AKI can relatively easily set them into the dialysis space, whether this intervention may impact outcomes. Also important to remember that ravulizumab and complement inhibition increases the risk of infection, especially with encapsulated bacteria. So the outcomes, the safety outcomes of this work will also be really important. All right, next we're going to talk about bicarbonate infusion. So metabolic acidosis is one of the most common things we see in critically ill patients with acute kidney injury. And to date, we really have not known what to do with it, whether it's something that we should replace if we're just treating the numbers, if it actually influences any patient outcomes. So it's hypothesized that metabolic acidosis may both directly or indirectly influence patient outcomes, including things like death, but also the requirement for organ support, especially ventilation and kidney replacement therapy. Therefore, it makes sense that treatment with a sodium bicarbonate buffer may normalize the serum potassium and prevent the need for subsequent KRT. So there's been interest in bicarbonate in AKI-associated metabolic acidosis for some time, but it's been reinvigorated with the BICAR ICU trial, which was a multi-center open label randomized control trial, a phase 3 trial. And this is a subgroup analysis of BICAR ICU looking specifically at patients with AKI. And in this subgroup, the investigators found that patients who were allocated to the bicarbonate group were more likely to be alive at up to 28 days compared to those in the control. And they also did a Bayesian reanalysis and found the probability that bicarbonate helped reduce mortality was 99%. So again, a positive signal. And on the basis of that, we've had a update in the Surviving Sepsis Campaign guidelines, such that now for adults with septic shock who have severe metabolic acidosis or acidemia with a pH of less than 7.2 in the presence of acute kidney injury of at least stage 2, sodium bicarbonate is suggested to be administered. So one of my colleagues in Australia, Ari Serpinito, he is leading the Sodabic program of work, which is now up to a phase 3 trial. So he started with a retrospective analysis looking at the prevalence and outcomes of moderate metabolic acidosis in Australia and New Zealand, and then studied what current practice is in terms of its management. He tested the feasibility in terms of the stability of the solution, but also the feasibility of blinding before surveying clinicians about what their perspectives were and running a pilot trial to look at the feasibility of randomization. And Sodabic is now running at several countries throughout the world. And we'll, again, hopefully have some results in the next sort of 18 months in terms of whether sodium bicarbonate is something we can give to patients who have AKI, and whether that reduces their subsequent risk of major adverse kidney events. And so this is limited to mechanically ventilated patients. So again, it's a slightly more clinically enriched group who are likely to have more complicated outcomes than some of the other patients. All right, and next we're going to talk about vitamin C. So vitamin C levels are known to fall in critical illness, especially in sepsis. And this is due to a combination of both reduced intake, but also increased oxidative consumption through the stress of critical illness. Oxidative stress is recognised as a major contributor to the pathophysiology of acute kidney injury. And one of the things that humans and guinea pigs have in common is that neither of us can synthesize vitamin C. And I think we may be the only species who can't, the two of us. So it's therefore hypothesized that the administration of vitamin C may actually reverse some of the pathophysiological response to severe physiological stress. So there's been quite a lot of work done in the vitamin C space over the last 10 years, and some of it has been quite confusing, and I think a lot of that relies on the fact that there have been different regimens tested, different doses, but also different formulations. So as a bit of background, we had a trial done by Paul Marek, which combined vitamin C or in the form of ascorbic acid with thiamine and hydrocortisone, and he showed a significant reduction in the risk of all-cause mortality in patients who received that compared to placebo. But subsequent trials like the vitamins trial and then the Lovett trial were unable to replicate those findings. And there was a lot of uncertainty about whether it was the bundle of care that should have been given versus the individual agent, whether the dose was appropriate, etc. And so there was then a lull and a bit of a disinterest in whether vitamin C was something that could actually help prevent acute kidney injury or improve survival in patients with severe sepsis. So the interest has been reinvigorated, led by one of my colleagues, Yogesh Lankadeva. So Yogesh is a professor of medicine, and he is working in a very well-established animal model of severe sepsis, looking at sheep. And he's really started a lot of the work in a different formulation of vitamin C. So this time it's sodium ascorbate, and also not just at high dose, but at megadose. So there's been quite a bit of a shift from the formulations that have been tested previously that had a very low pH. And the pH of the sodium ascorbate is very much physiological. So Yogesh has started now over the last couple of years a body of work looking at the impact of megadose sodium ascorbate on outcomes both in sheep, and then we've also done some human work. So we can see that so in sodium ascorbate in the blue, there's a reduction in noradrenaline dose. There's an increase in medullary perfusion, but also medullary oxygen tension. increased urine output, decreased plasma creatinine, and similar blood pressure. That's compared to noradrenaline. So vitamin C does have some diuretic effects because it's hyperosmolar, and we can see that total urine output over 24 hours was increased with megadose sodium ascorbate compared to placebo, and that over time, over the first 24 hours, there was a gradual increase in the cumulative urine output. So whether that's relating to differences in renal function versus to an osmotic effect is not entirely clear, but requires further investigation. So that further investigation is coming in the form of the Megascores research program. So we've recently been funded to roll this out across a number of sites. So this program is going to include numerous aspects. So there'll be some animal work in both small and large models of severe sepsis. We'll also have phase 1 and phase 2 clinical trials in humans, taking the learnings from the animal model and translating them into the human context. And so this is something that we've started over the last 6 months and we'll be working on for the next 5 years, and which we look forward to talking about more in the future. So bringing that all together, what's new and emerging in acute kidney injury? So firstly, we've moved away from the very heterogeneous classification of acute kidney injury as a syndrome that's just defined by changes in creatinine and urine output. We're now, at least from a clinical standpoint, classifying it as phenotypes in terms of severity, duration, and also the number of episodes. We're going one step further and looking at it in terms of subphenotypes by trying to identify what the dominant mechanism that's driving injury may be. And hopefully with time, we'll get better biomarkers to help differentiate between those mechanisms to help subsequently guide both prognosis, but also predicting response to therapies. It's possible that in the future, with advances in gene technology, we may be able to identify specific gene mutations that are contributing to either the development of a specific phenotype or also the response to a particular therapy. In the past, we've had an approach that's really taken a one-size-fits-all approach to AKI. We've taken very heterogeneous populations of patients and we've tested a single intervention. And almost always it hasn't been effective in terms of reducing early and late adverse outcomes in the overall population. But we're hoping to build on our understanding of the importance of mechanisms in guiding treatment decisions to try and, once we've been able to identify the mechanism, to then determine what the appropriate therapies may be. So if we break it down into the mechanisms that we are aware of, so looking at patients who have predominantly microvascular or macrovascular dysfunction, we'd be looking at testing things like angiotensin II, which has differential effects on the ephrine and afrin arteriole, and at least in the Athos research program, was associated with earlier liberation from renal replacement therapy and better survival. And both of those factors were exacerbated in patients who had a high baseline renin. So that's patients who we suspect have dysfunction of their RAS, contributing to their presentation of disease. We've also had really positive information from the protection trial on the potential role of amino acids. And it's hypothesized that they also cause some changes in the renal microcirculation. So some vasodilatation of the afrin arteriole, increasing the glomerular filtration rate and recruiting quiescent nephrons. Although we did see a reduction in the incidence of acute kidney injury with amino acid therapy, it was largely limited to stage 1 AKI. And we're not really sure how clinically meaningful that is in terms of patient-centered outcomes, since it's really a change in a biochemical marker. So what we're now going to do is to look to see whether in patients who've got CKD at baseline, whether the reduction in stage 1 AKI results in things like reduced kidney replacement therapy, and reduced de novo or progressive CKD at 90 days, so that we can then better understand which patients may actually benefit from amino acids. At least they appear very safe, but there is a cost benefit. There is a cost to the hospital if they're administered, so needing to determine their efficacy before routine implementation. From an inflammatory standpoint, we've had lots of different inflammatory therapies tested over the past 10 years. And we're currently doing trials looking at the impact of complement inhibition. So this is with ravulizumab, looking at a terminal complement inhibitor to see whether in patients with chronic kidney disease, this can decrease the complement activation and decrease major adverse kidney events in a particularly high-risk group. Then looking at oxidative stress, there's a number of different interventions that are being tested that may mitigate oxidative stress. So sodium bicarbonate is being tested in patients with severe metabolic acidosis in the context of AKI to determine whether that's an intervention that reduces the need for subsequent kidney replacement therapy, but also has impacts on major adverse kidney events and also survival. We've also just started a research program on megadose sodium ascorbate to see whether this therapy in both preclinical and clinical studies can positively impact sepsis outcomes, both in terms of organ function, but also physiological markers and eventually survival. So bringing all of this together, what we really need to move towards is personalised care. So we've started with a very heterogeneous condition that we've made very little progress in terms of how to treat beyond providing standard sort of supportive measures, but we're very hopeful that over the next 10 to 20 years, we'll better be able to identify individual subphenotypes within patients for which we'll have tested targeted therapies to then enable the delivery of personalised care in our ICUs. Thank you.
Thank you for that fantastic overview. Okay, yeah, we are all back on. So if people have any questions, please unmute yourself and ask. And thanks again for that great overview. It's really nice to see trials still being done in AKI. We don't have anything that works, so it's really good to see that we are still testing stuff that works. While people are, figuring out what to ask, if I could start the ball rolling, how should we think about angiotensin? Like from a nephrology perspective, we think angiotensin II is bad, hyperfiltration is bad. So is angiotensin II just a better vasopressor, or is it doing something? Do we think it's doing something at the renal level that is good for the kidney?
So I still work clinically in both nephrology and intensive care, and I always joke that on Tuesdays I block the pathway, and on the other days I give it intravenously. And it's a really complex phenomenon between the acute organ failure and the chronic organ failure. And we see the same with heart failure and beta blockers versus beta agonists. So in acute heart failure, it's dobutamine, and in chronic heart failure, it's beta blockers. And just observationally, at least, there's been a lot of discussion amongst critical care nephrologists that the same seems to be true for the renin-angiotensin system. So there's been quite a lot of work done following on from ATHOS-3 to try and understand why it is that some patients responded so well and why those patients had a high renin level. And what they hypothesized was that because the angiotensin converting enzyme is bound to the endothelium, and because the endothelium is often damaged in shock, that the ACE either becomes dysfunctional or is decreased in concentration. So these patients actually have a reduction in their circulating angiotensin II. And as part of the ATHOS-3 trial, which hasn't been replicated in sort of the subsequent studies because it's too unstable, but they actually did angiotensin I and angiotensin II assays as part of the trial. And they did show that the patients with high renin level tended to have a high angiotensin 1:2 ratio, suggesting that they were they were making a lot of angiotensin 2, but they weren't able to convert it to, they were making a lot of angiotensin 1, but they weren't able to convert it to angiotensin 2. So at least that supports that hypothesis, but it's by no means definitive. There's also been a lot of work done at different polymorphisms of the angiotensin II type 1 receptor and whether that influences responsiveness to angiotensin II versus other vasopressors. But it's been shown now in 3 different trials, Athos 3, our initial RMS pilot study, and one other, that a high renin level does appear to be predictive of response to angiotensin II therapy, which is really great because we don't have any markers for response to norepinephrine. And even though copeptin is thought to be a marker of response to vasopressin, it hasn't really been tested conclusively. So for us, in our ongoing work, and pretty much everyone who's doing trials in angiotensin II at the moment is testing renin both at baseline and at 24 hours just to see whether the signal is consistent. But one of the challenges with it is we actually don't know what a normal renin is in a critically ill patient. And so all of the studies have dichotomized at the median. And interestingly, the median in pretty much all of the trials is the same. It's all about 170 picogram per mil. So there is at least consistency, but we need to know a lot more about where that preferred threshold is in terms of responders versus non-responders. And to better understand that, we need access to real-time renin testing so that we could use that to help stratify our randomization. Technology that is being worked on, but it's certainly not available yet. But hopefully in the next sort of couple of years, at least, we'll have the capacity to do that so that subsequent trials can build that information in.
Thank you. That does, it's somewhat reassuring to see that there is more thought rather than just look at some numbers. Dylan.
Yeah, great presentation. I had a question about the protection trial. I know I'm not quite sure about the formulation of amino acids, but I know there's a bunch of amino acids that are pretty potent stimuli for platelet activation. So any concerns about thrombosis, any information we know about that in the population?
Yeah, so when they look at the overall sort of dose of amino acids, it's about the same as having sort of 20 bottles of concentrated albumin a day. So it's quite a lot of protein, and certainly thrombosis was a concern in terms of potential complications. In the study, the study wasn't powered for that, but there was no significant difference between groups. But there's been actually a lot of discussion about the whole amino acid AKI situation, because when we look at protein in terms of how we're feeding patients, so when we look at protein concentration in enterally fed critically ill patients with AKI have worse mortality if they're receiving high protein. And so now there's been this disconnect where, okay, so patients are having cardiac surgery and they get intravenous amino acids and they have better outcomes, less AKI. But then if we feed them with more protein, they tend to die more if they've got AKI. So there's still a lot to unpack in this space. And I think what it will come down to is phase 4 implementation studies, where we actually use it as part of routine care in a trial setting, and then collect data on all of the potential relevant outcomes that, weren't explored in great detail in the clinical trial, to fully demonstrate the safety. Because if the only efficacy is a reduction in serum creatinine at stage 1 and there are safety concerns, then, the risk benefit's really going to change. We don't yet have the health economic analysis for protection, but one of the health economists from Monash Uni has gone over to Milan to start working through that data because it couldn't leave the EU. So we had to send the investigator. She was very happy to go to Milan. There was no problem. But yeah, so I think that will be the other interesting element, where if this is an expensive therapy and it doesn't reduce expensive complications like need for kidney replacement therapy, then we need to actually balance who would receive this and where that sort of cut point is as well. So it kind of, I think it's a real shame with protection is that no one actually knows how it works. So there was not a lot of animal work. There weren't a lot of pilot studies, and they kind of went almost immediately to a phase 3 and then found a benefit. So they're actually having now to go back and do some animal work to better understand whether this is something that it's recruiting the renal functional reserve, which was thought to be the primary hypothesis, but then also is it improving endothelial function because, you know, albumin may improve the glycocalyx. You know, they haven't actually worked out what the mechanism is. So it's sort of the reverse of how we normally do a trial where they start with the phase 3 and go backwards, which is very frustrating.
Yeah, thank you. Can I ask a little bit more about the protection trial since it came up? And it's kind of, when we discussed it at our journal club, there was a lot of skepticism, which is kind of interesting because, you know, we keep complaining that people don't do trials. And then when a trial is done, we say, oh, we don't believe it. So the concern about that was brought up in the discussion was that maybe, you know, it just causes as you alluded to, maybe it just increases the GFR number, right? It just decreases the creatinine number, maybe, you know, hyperfiltration or what have you. And they didn't have any biomarkers, unfortunately, which should have given us some reassurance. So before we go to phase 4 kind of studies, do you think there will be any, should we believe this or should we, there was a lot of discussion about, should we try to replicate these findings? Is that something that you see happening or this is good?
Yeah, I can tell you that you're not alone in your skepticism because one of my, you know, mentors, Ronaldo, was involved in this. And I think we all feel the same way, that you've shown that there's a reduction in peak serum creatinine when you give a protein load, which we could have just given to a healthy person and showed the same thing. But unfortunately, that's how we currently define acute kidney injury, as changes in sort of glomerular filtration rate. So what's going to happen is that so the plan is to embed biomarkers into a phase 4 study. Because that's something that would have been really helpful if they'd done in protection to try and convince people, especially given the real benefit was just in stage 1. If you had stage 1 reduction and a reduction in biomarkers, I think people would feel a lot more confident that there was some benefit rather than just a functional change like a RAS inhibitor or something that's causing a change in GFR without causing actually any difference necessarily at a structural level. So one of the plans from the protection group is to do some phase 4 study that has some biomarkers work embedded, and then also to follow patients up more consistently after discharge to look at that subsequent CKD risk. Because we do know that, you know, from other studies, other observational studies, that patients, even with stage 1 AKI, are at subsequent risk of CKD, whether that relates to their AKI itself or shared risk factors or something else entirely can't be proven because it can't exclude the confounding. But I think that would also make people a lot more confident that there was some benefit in patient-centered outcomes if that was shown over, you know, an outcome like chronic kidney disease. So yeah, I feel like, you know, even in my own journal club, there was so much skepticism. I'm skeptical, but yeah, it's true that we complain that there's no therapy for AKI and then they give us one and we don't believe it. But I think we have to question it. Yeah.
Cool. And how would you think about, you know, embedding more of these? I know biomarkers are still a work in progress, but in terms of outcomes, should we require them to be part of the outcomes? Because sometimes we see changes in creatinine because of volume status or hemodynamics or what have you. Yes, it is the stage 1 AKI that KDIGO still has as the definition, but do we need some markers of tubular injury or, you know, whatever, reperfusion, repair, one of these biomarkers as part of clinical trials? How should we think about that?
Yeah, I think there's certainly a need for a biomarker that's better than creatinine, but the currently available ones just haven't consistently outperformed creatinine. And so we can't really justify them based on the fact that they're quite expensive as well. So I don't know what it's like in Canada, but we currently don't use any novel biomarkers in Australia, like NephroCheck, NGAL. We don't use them. They're not available outside of research settings. So for us, it's something that is not part of our routine care. But I'm aware that in the States and in Europe, they're ordering them on their ward rounds and they're making management decisions based on them. And some of the work from Alex Zarbok has shown that if you take, you know, a biomarker positive patient, clinically enriched population, and apply the KDIGO guideline in cardiac surgery patients, that you can reduce the incidence of severe AKI. So at least in that study, they showed that you could clinically enrich a population using biomarkers, but it just hasn't been enough to convince us to get them. So for us, we don't use biomarkers in anything, but when we have, international consensus guidelines, the Europeans are like, what do you mean you don't use, NephroCheck and all this? And I think that everyone's desperate for something, but we just don't know what the right answer is. So KDIGO is a bit stuck because it's currently rewriting the AKI guideline and with a revision of the definition. And there's a bit of uncertainty as to whether to classify within each creatinine urine output stage, whether there's a biomarker positive, negative status. So like 1A, 1B within, just to further risk stratify. So I don't know what they're going to end up doing. Because there's sort of arguments both ways, but I think everyone agrees that there's a need for a better biomarker that actually reflects injury rather than changes in function. And certainly that would just shed so much light on an intervention like this, which is actually has a known impact on GFR, but not necessarily in a structural way, but definitely in a functional way.
Yeah. So even in Canada, we don't have NephroCheck or NGAL that we can order. We are, similar in terms of trying to.
We're both sensible.
Yeah,
countries.
exactly. Saving money until we figure out how useful it is. On the vitamin C aspect, the sodium ascorbate now, I guess, there has really been a roller coaster, right? Like after Paul Marrick's before after study, everybody started using Marrick protocol.
Yeah.
Question is, since we went to Zoom.
Oh, did the conference room have a question? Not.
Yes, I did.
Okay, I'll finish mine and then I'll come to you.
Mine was a vitamin C question.
Okay, so why don't you go ahead? Yours may be more sensible than mine. Go ahead.
Well, no, it's more a curiosity because, of course, we mostly think of megadose vitamin C as something you get at the Shyster Alternative Medicine Clinic. And I'm interested in the human trials, how much will be given, because I quickly looked up the sheep trial and it was 1 gram per kilogram.
Yeah.
So is that how much will be given? Is there any concern about metabolism to oxalate or any other bad things like that?
So this is a really good question. So the answer is 3 grams per kilo. So, and the safety rationale is that it's been given at higher doses to cancer patients, so to oncology patients as part of various, I think, prostate cancer therapies. And in the sheep, that was the dose that had the most efficacy. But this is, 3 times what was being given in a lot of the other studies. And certainly the formulation, the ascorbic acid formulation, had a pH of sort of 3.5 to 4. So you just couldn't give that much in that formulation because the would have killed people. Now the sodium ascorbate formulation does have a slight problem in that it's got sodium, and that's a lot of sodium to be giving critically ill patients. And so hypernatremia is one of the main issues we've run into. And so it's not given all as a bolus, it's given as an infusion. But we have noticed people sort of getting up to sort of 150, and, hypernatremia is already such a common problem in patients with AKI who are on loop diuretics and, just losing free water. So it may end up being a bit of a problem. My concern, I think I'm the only nephrologist in the team. So I was concerned about oxalosis. Everyone else is like, oh, you nephrologist and your oxalosis, but we haven't seen any of that. But obviously that's, the other, major complication,
biopsy, that's about it.
Yeah. Well, that's you could actually be like sparing their AKI, but creating a little bit of CKD, you just, that's been, certainly one of the concerns. In the sheep biopsies, there hasn't been any oxalate deposit, but the sheep are one of the animals that do metabolize vitamins, make their own vitamin C. So I don't think we can, that's been the other issue with the translation from animal to human models, is that how do you compare an animal that can make its own vitamin C to one that doesn't? Because then the infusion is quite different in terms of what they're used to being exposed to. So there's also sort of more complexities there. And, you know, this is one of the problems we run into with a lot of trials in animals that don't translate to the human setting, because at the end of the day, they're different species and they've got different physiology and different, you know, mechanisms of drug clearance and metabolism. So yeah, I think for us, it's going to be like, certainly the initial part has been really positive, but there's certainly a lot of hurdles to get through before we, you know, even get to phase 2 data with this work. But we wanted to reiterate that, so we say sodium ascorbate or vitamin C is not dead, it's just been rebranded.
Was there, that was going to be my question also about the oxalosis. So it's fantastic that you did cover that. Was there anything else from the conference room? No, it's all good. Okay. Yeah. So again, it's almost 11 o'clock for you at night in Melbourne. So thank you again for that wonderful overview of the AKI phenotypes, as well as all the trials that are in the works. So to the viewers, we have recorded this. It will be posted on our YouTube channel sometime next week, and you will all get an email with the survey for feedback. So thank you again, Dr. C, and hope to see you at Kidney Week in San Diego.
I'll see you all there. Thanks for having me.
Thank you. Bye-bye.
Bye.